All right, everyone, thank you so much for joining us in this session today. We've got Before the Ambulance Arrives, Reimaging the Role of First Responders in Bicyclist and Pedestrian Safety. Emergency responders play a critical role in determining the severity of injuries and the long-term outcomes of individuals who are involved in motor vehicle crashes. Today's panelist will describe the role that emergency services plays in improving safety for our vulnerable road users and share strategies for working closely with first responders to shape pedestrian and bicycle safety programs. First up today, we have Michelle Reyes. She is a senior research associate at the University of Iowa Driving Safety Research Institute. She conducts human factor and traffic safety research in a range of areas, including consumer education about ADAS, training and education of novice drivers, driver interactions with farm equipment, and the analysis of crash data to study drivers' behaviors and those crash outcomes. Michelle is the committee research coordinator for the TRB Standing Committee on Vehicle User Education, Training, and Licensing, and is the vice chair of the Young Driver Subcommittee. Just a second. Next after that, we will have Mike Wilson. He serves as the appointed commissioner for the City of Berkeley's Disaster and Fire Safety Commission. He holds a PhD in Environmental Health Sciences and a Master of Public Health from UC Berkeley. In his day job, Dr. Wilson is a senior safety engineer in Cal OSHA's Research and Standards Office, where his work includes fire safety and health issues. He previously served for 13 years in EMS and fire services as a paramedic and an EMT and fire paramedic in the city of Salinas and Santa Cruz County, and with the U.S. Coast Guard Reserve Station Monterey, as well as FEMA Urban Search and Rescue Task Force that was hosted by Oakland Fire. Lastly, today, we have Robbie McHugh, who is the Assistant Chief of EMS Operations at the Colony EMS Department in Albany, New York. He holds a master's degree in healthcare leadership from Case Western Reserve University and an undergraduate degree in information systems. He has served his community as a paramedic for over 40 years and is a board-certified flight paramedic. Chief McHugh has played a key role in securing funds and advancing initiatives for roadway safety under a Safe Streets for All initiative, as well as a Safe Streets for All collaborative grant that includes elements of post-crash care, prevention, and working with various stakeholders from state and local levels on innovations across the various domains of our safe system approach. First, we will welcome up Michelle.
Good afternoon, everyone. I always love being the first speaker after lunch. So I'm pleased to be here today to share some of the work that I've done with some of my colleagues at the University of Iowa Injury Prevention Research Center, especially Dr. Kara Hamann and Nicole Corcoran, who is a PhD student at Arizona State. So I'm going to discuss our work looking at road conversions, so going from a 4-lane roadway down to a 3-lane roadway and how that affects emergency response. So what are we talking about when we say a lane conversion or a 4 to 3 lane conversion? Sometimes these are called road diets. Raise your hand if you've heard of a road diet. Okay. So looking at the history of this, that's provided by FHWA. So in the 50s and 60s, there was this kind of a focus on expanding capacity, and so a lot of roadways went from 2 lanes up to 4 lanes. But the trend to start reducing lanes happened as early as 1979. And they really gained popularity in the 90s, especially in our state of Iowa, in Minnesota, and Montana. So the appeal of doing one of the appeals of doing lane conversions like this is that they can be relatively low cost. It's just a matter of picking up the paint lines that were already there and putting down new striping. So what are the benefits? Why would a community want to consider a lane conversion? It's designated as a proven safety countermeasure. It reduces crashes between, say, 20 and 50% thereabouts, mainly due to reductions in rear end, left turn, and side swipe crashes. So this diagram shows the conflict points on a 4-lane divided roadway. So you've got 2 lanes where there can be rear ends. You've got, if you wanted to turn left, you could get struck from the rear. While you're waiting to turn left, you have to cross 2 lanes of traffic. And so there's also, the decrease in crashes is also, there's more benefits for drivers who are under the age of 35 and over the age of 65. It's also benefits for vulnerable road users like pedestrians and bicyclists, because if you are waiting to cross the street, you only have to look at 1 lane to your left at a time, 1 lane to your right at a time. A lot of designs incorporate pedestrian refuge islands in that center as well. So what are some of the challenges and barriers to doing this? So garnering public support can be a challenge. People who are kind of concerned about the project might bring up increased travel times and congestions. I mean, there's some logic to that, right? Like, we're going from 2 lanes of travel in each direction down to 1. How can that possibly be an improvement? And, you know, there can be some skepticism in some communities about federal guidance. So we were approached by our DOT in Iowa to take a look at some of these concerns, namely looking at business impacts and then the emergency response. So I'm going to cover the emergency response work today. So we did a multi-method approach. So we did a qualitative analysis using fire response data, and then we did survey data and did qualitative analysis of that work. So for the fire response analysis, we got data from the National Fire Incident Reporting System. This is a clearinghouse of data, and departments can submit their data voluntarily. There's not a mandate for them to do that. So for this part of the project, we looked at 4 road segments in Cedar Rapids, Iowa, that were converted between 2016 and 2019, and we got fire incident data some of it came directly from the Cedar Rapids Fire Department due to delays or latency of getting the data out of the NFIRS system. And we looked at the response time from alarm to arrival at the site. So we took the call address and the station that the unit was based at, the unit that responded to that call. And we made the assumption that the responders took the shortest route from that fire station to the incident address. We used a Poisson regression model, which is typically used for count data, and we analyzed each trip. And the dependent variable, what we're measuring, is the response time, but we included an offset, so that takes into account how long the trip was. So ultimately what you're getting is a rate, the time over the distance. And then we looked at before the lane conversion and after the lane conversion. So we included as many years of data as we could, at least 2 years before the conversion and at least 1 year after. We also included a number of covariates to control for the time of year, namely whether it was a winter month or not, if it was a peak travel time or not, and then how much of the trip covered or went over the road segment. So a lot of these conversions are only maybe a half-mile long, while the trip to the emergency call probably was longer than that, and it just traveled on the converted segment for part of their trip. So we weighted that. We also took into account what the speed limit was on that. We also looked at the annual average daily traffic for that roadway, which was really collinear, really correlated very highly with that weighted speed limit. So we used the speed limit instead of the AADT. Also the number of lanes and traffic signals. So this graph shows our findings. So the red data point with the error bars is the before, and the green is the after. So we generally did not find any difference in travel rate before and after the lane conversion. And again, these are adjusted for all those covariates that I mentioned before. So we do not see any evidence that response times changed after lane conversions that were done in Cedar Rapids, Iowa. Looking at the survey side of the project, we worked with what was then at that time Iowa Department of Public Health. They've now had a name change and merged with some other state agencies. But we worked with the Bureau of EMS and the Iowa Department of Public Safety to reach out to EMS and fire personnel in 10 different communities in Iowa that had lane conversions, and I don't remember off the top of my head the range of dates, but they had to have been fairly recently at the time that we did the survey. So we had 170 responders complete the survey. About 2/3 of them provided both fire and EMS services. 16% or so were fire only, and 10% did more than just fire or EMS. So one of the things that we asked them, and one limitation of this research, is that we were asking them after the fact, how did you think back to before the lane conversion? How did you feel about it? So that's a big limitation. We were not able to, we had considered doing a prospective study, and maybe one day we still can, but that was not the approach that we were able to use. Also, we did data collection right about 5 years ago. So if you all remember what was happening 5 years ago. So we did word these questions outside of the effects of the pandemic. Like, don't think about all the wacky stuff that's going on right now, but before that. Before the lane conversion, did you think that it would have a positive or negative effect? And if you notice, 23% of our survey respondents told us, I didn't even know it was going to happen. They were not aware. Now, if we take the people who were unaware out of the sample, the dark line is the before and the colored lines are the after. So we can see kind of what was the shift in the distribution from before to after. And there's not really a big shift in total numbers. The proportion of negative went down a little bit, the proportion of positive went up a little bit, but not a whole lot of change in the distribution as a whole. However, if we look at the individual level of change in opinions from before to after, so the the y-axis on the left is the before, and the colors in the bar are the after. So the biggest proportion in each group stayed the same. There were the biggest proportion did not have a change. So we had most people, the biggest block or biggest combination of these was people who had negative perceptions about the road conversion before, and they remained negative after. Altogether, this highlighted block represents 14% of the respondents. And I apologize, something must have shifted, so my bars aren't lining up. The next biggest group were people who didn't think it would have an effect. And then the next biggest group was the positive. They had positive expectations and reported positive opinions after. So altogether, to summarize kind of what that change looks like, just over half the respondents reported holding the same opinion after the conversion, and 30% actually reported effects that were more positive. Now, to be clear, they're not saying positive, that wasn't their response, but they shifted towards the positive side, while 17% shifted more negative after. For those who were not aware of the lane conversion before it happened, we see a little bit more skewing towards the negative. Again, I don't know where my percent side, so that should be 46% on the yellow, so they're either expected no, or they reported that it didn't have an effect or that it had mixed effects, and a little over a third of the people who were not aware before had negative opinions after. We also asked them if they think that what their perception was of the response time for the calls. Over half of the respondents said that they felt that the calls were the same, took about the same amount of time. But of the people who noticed a change, it was much more heavily skewed. More than a third of the people thought that the response times were slower. And compared to before the lane conversion, almost the same number of people thought that it was less safe, slightly less safe. If you combine those together, that's 36% of the sample compared to 38% who said no change. And finally, we asked then we asked them if they drove, if they were someone who drove the apparatus on calls. And if they were, we asked them, when you have a choice in your route as a driver, do you prefer or avoid traveling on the road segment? And here it's very interesting that only 14% of those drivers said that they try to avoid the lane conversion. So even though I have some negative perspectives, it doesn't necessarily bear out in their behavior. So as I said, with surveys, we did have a number of open response fields, and so we did do a little bit of text analysis on those, but I just have a few things that some of the responders who had negative opinions of the lane conversion shared with us. So now that this person observed that drivers think if they pull into the turn lane, so that center two-way turn lane, they think they're getting out of the way. This one reported that sometimes they have delivery trucks stopped in the center turn lane that impedes their ability to respond. If there's a driver already in the center turn lane, they've seen them not want to leave the center turn lane and move to the right, and they may just try to force that turn, and which, of course, creates additional conflict and potential for another crash. And the vehicles, kind of to that same point, vehicles in the center turn lane usually don't want to move. And then this one observed people don't get over to the right. I don't know why they're not getting all the way over to the right. Maybe it's because they think that bike lane is off limits, that the cars aren't supposed to ever use that space. And then this final observation that included, it was really interesting. So because of the way that the lanes are shifted, if an apparatus is trying to make a turn through an intersection, they have less space to do it. Because of the lane configuration. So before they would have had half the width of the road, and for them to turn the apparatus into the actual travel lane in that direction, it restricts their movement somewhat, gives them less space, especially if there is a vehicle in that turn lane at the intersection. So just to summarize, 23% of the responders told us they weren't aware of the lane conversion before it happened. One of their open responses was EMS was not brought to the table to discuss impacts. And those who weren't aware before did tend to skew towards more negative perceptions or reported more negative effects. However, most responders did not change their opinions after the conversion or what they said their opinions were from before. And so I think that there's some evidence that people just it's hard to change people's minds in some cases. And nearly equal numbers said that it was less safe as said that there had been no change in safety. And then as far as response times go, again, over half the people who responded reported no effect on response times, but a third about said that the response times were slower. And looking at those 4 lane conversions in one community, we found no changes after the conversion. So just a few things that we would probably suggest that communities consider is engaging emergency responders and other community members early in the process of doing a lane conversion or other road safety project. There seems to be a real need to educate drivers about the right way to move over and yield space for the first responders. And I strongly encourage communities to get your own data for your community, whether that's from your fire department. Maybe put dash cams in your fire trucks and ambulances in your communities. Directly observe what those responders see when they're out on the roads. Look at the response rate distributions for your community, and also think about what proportion of trips would travel through that area that you are thinking about modifying. So I'd like to acknowledge the Iowa Department of Transportation, the rest of our project team, and we also had a technical advisory committee who provided input on our project. And most of these findings are in this journal article that has been published. And these slides are not yet on the Lifesavers site, but I will get them up there. So with that, I am done.
Thank you.
Thanks, everyone, and good afternoon. I'm really happy to join the panel today. And Professor Reyes' research and findings are extraordinarily important for a number of reasons. And the first, and sort of going to be the presentation of my talk here, when I have to click that, is that at least in 10 major cities across California and 8 that we've counted so far nationally, fire departments have found themselves in the position of opposing important street safety measures over concerns about access by fire apparatus, response times, and sometimes evacuation routes. And sometimes this has resulted in important street safety measures being vetoed by city councils and so forth. The key point in my presentation today is that the fire service has a long and remarkable history and record in fire prevention. And it now needs to expand its fire prevention mission to include street trauma prevention, embracing Vision Zero. So that's what I'm going to talk about today, our experience in the city of Berkeley, street trauma prevention, implementing Vision Zero at the Berkeley Fire Department. So briefly, what is Vision Zero? In Berkeley, our 2019 Vision Zero action plan describes it as a strategy to eliminate all traffic fatalities and severe injuries while increasing safe, healthy, and equitable mobility for all. And continuing, it is first and foremost an engineering strategy that aims to design and build our streets to eliminate severe and fatal traffic injuries. These engineering efforts are supported by public education and traffic enforcement, but the primary focus is on designing streets. And that means streets that are designed in such a way that speeds are reduced and such that if a driver loses their attention or acts carelessly, they'll hit a concrete barrier or parked vehicles, for example, rather than plowing into a bicycle lane. Vision Zero in the city of Berkeley, as it's stated in our policy, strips away the societal acceptance that fatal and severe traffic collisions are a necessary byproduct of mobility. So it also, the concept of Vision Zero really aligns well with the California Fire Service and with the Berkeley Fire Department specifically. And that mission is to protect life, property, and the environment through prevention, community preparedness, and emergency response. So less abstractly, Vision Zero is about preventing what happened in this picture. This is the aftermath of a collision with a cyclist who was on her way home from work on February 2nd, 2016, wearing a reflective jacket, 2 bright flashers going, when she was hit from behind by an impaired driver, pulled under the car and dragged 60 feet through the intersection of Fulton and Bancroft streets in Berkeley. When Berkeley PD arrived, they assumed the cyclist was deceased, and they called out their fatality accident investigation team. Berkeley Fire arrived shortly thereafter with an engine, a ladder truck, 2 medic ambulances, and a battalion chief. They extricated the critically injured cyclist. They began resuscitation. She was in respiratory arrest. They loaded her into an ambulance with 3 medics aboard for transport to Highland Hospital's trauma center. Let's see here. So who was this cyclist? It was Dr. Megan Schwarzman, a 44-year-old physician and environmental health scientist at UC Berkeley and mother of an 11-month-old boy at the time. Berkeley Fire medics was clear that they had obviously a critically injured patient. She had 5 pelvic fractures, 36 rib fractures, a right side pneumothorax, left side hemopneumothorax, an orbital facial fracture, clavicle fracture, lacerated liver, multiple abrasions, and severe internal bleeding. They got her to Highland Hospital within minutes of arresting. And it was apparent that, so she was in a coma for 5 days, essentially, at Highland. And after 8 days, she began communicating by attempting to write on this erasable board. She had 5 major surgeries to staunch the bleeding from her liver and repair her lungs and fractures, and more surgeries were coming. What the trauma surgeon said was that after the crash, time was precious. The trauma surgeon later told her, had it taken 5 more minutes to get to Highland, she wouldn't have lived. So her assessment was that she would probably be at Highland Hospital for 6 months recovering from this. But she was out in 5 weeks, and she survived. And the miracle of her survival was so unexpected and extraordinary that about 6-8 weeks later, the Berkeley firefighters who saved her life gathered at Fire Station 2 to celebrate her and her family. And these are the members of Truck 2, or Engine 2, Truck 2, Medic 2, Medic 5, and Battalion 2 in front of Fire Station 2. And so they held this celebratory dinner with a fantastic taco bar and set the tables up for everybody to join. And they did this because it's extraordinarily unusual for firefighters to pull someone out from under a car and for that person to live. And I'll say in my 13 years in the EMS and fire service, I never pulled someone out from under a car who survived. So Meg Schwarzman is my wife. And her physical recovery, continues, and as well as our families. And our medical costs for this have been between $800,000 and $1 million. So single incident. Others in Berkeley are not so lucky. So these are data from fatalities from 2017 to 2022. Pedestrians killed in green, cyclists in blue, and vehicle occupants in yellow. And what we're seeing basically is 5 fatal injuries each year on average over this period from street trauma. When we look at the serious injuries, these are injuries that cause or require an EMS response. So we have a little under 700 collisions involving injuries to vehicle occupants, cyclists, and pedestrians, again between 2017 and 2022, just in the city of Berkeley. So when we looked at what was happening in the fire department, we could see that, just looking at the data, that vehicle occupants, cyclists, and pedestrians involved in collisions that require a response by the fire department have been 694 per year on average, and persons injured in structure fires have been 2 on average between 2010 and 2022. So what is going on here? So the success of the prevention arm of the fire service has resulted in large part from decades of advancement in fire prevention. And this was prompted in 1973 by the report of the National Commission on Fire Prevention and Control. And this was a report called America Burning, and we've just passed the 50th anniversary of the release of that report. And the report highlighted the importance of fire prevention as an essential role of the fire service alongside suppression. And the report motivated Congress to pass the Federal Fire Prevention and Control Act of 1974. From that report, I found this really interesting. Currently, about 95 cents of every dollar spent on the fire services is used to extinguish fires only about 5 cents is spent on efforts to prevent fires from starting. Much more energy and funds need to be devoted to fire prevention, which could yield huge payoffs in lives and property saved. The Commission recommends that all local governmental units in the United States have enforced an adequate building code and fire prevention code, or adopt whichever they lack. The Commission recommended that fire departments build a comprehensive approach to fire and life safety, including prevention. It's got a little bit wanky here, but the report called for fire departments to continue fire suppression efforts, to adopt paramedic services, to build a real fire prevention program, fire safety education, address high hazard structures, coordinate efforts regionally, collect the data, and build in community relations into their efforts. And the results are pretty astounding. This is U.S. Civilian fire deaths and home fire deaths from 1977 to 2022. And you see a 64% decline over these 33 years. And so that comes to 5,000 fewer deaths between 1979 and 2012. And when you think about the kinds of things that have driven this on the fire sort of prevention side, what we've seen since the release of that report has been a steady stream of fire protection codes that require the use of passive and active fire protection systems, design specifications for buildings, fire-resistant building materials, exit systems, fire sprinkler systems, smoke control systems, heat and smoke alarm systems, and so on and so forth. And so this has worked. It's been a combination of engineering, enforcement, education, outreach, and all of those efforts. So my view of this is that this it's an exemplary record of achievement in prevention in the fire service, and that approach can and should now be applied to the problem of street trauma. And so why is that? Of course, based on our own experience in Berkeley, but this is something we've been people have been talking about over the last couple of days. The real meteoric rise in pedestrian fatalities resulting from collisions with vehicles. This is data between 1980 and 2022. After a 30-year period of decline between 1980 and 2010, we saw we've seen this real, marked increase. And the question is, why is that happening? And there have been a number of analyses about this, and there were some of the presentations this morning about it. But I think fundamentally, and what we've seen in several analyses is that basically the U.S. transportation system is designed to move vehicles quickly, not necessarily to move people safely. And some of those specific drivers of the trend include wide and poorly lit streets with speeding vehicles, drivers distracted by phones, using automatic transmissions, the size of cars that hit walkers in the chest for blunt chest trauma and limit visibility, and others. So our experience in Berkeley tracks this national experience. Severe and fatal collisions disproportionately affect pedestrians and bicyclists. Residents report that they walk or bike for 40% of trips, but pedestrians and bicyclists suffer 60% of severe and fatal collisions. Drivers operating at unsafe speeds and failing to yield at crosswalks are the two most common violations, contributing to severe and fatal collisions, amounting to 33% of incidents over the period 2011 to 2020. And while 71% of Berkeley residents report being interested in relying on bicycles for daily use, most are too concerned about safety to act on this choice. So when we look at how this is distributed across the city, these are severe and fatal collisions over the period of 2011 to 2020, and it's there's a dot, 295 dots out of 357 severe injury and fatality traffic crashes that occurred on our streets. And what you can see is that it's basically, this isn't a problem that's isolated to a few problem areas or intersections or what have you. It really is uniformly distributed across the city. And that suggests to me that we have a fundamental street design problem, uniformly sort of from border to border. So a couple of key sort of points here. I think fire agencies should now apply the lessons of fire prevention to street trauma prevention. So a couple of principles here. One is that quick response and hospital return times are essential to save lives. And my wife, Meg Schwarzman, is sort of exhibit A as to that point. Principle 2, however, is that trauma prevention is also essential. This is sort of the other side of the coin from trauma response. And this is the intersection of Bancroft and Fulton, where Meg was run over from behind. And what you see here is if you're a cyclist on this top left corner, and you're actually in a bike lane right now, and the bike lane is shown in that bottom picture. As you cross the intersection, the bike lane dumps you into the right-hand lane of traffic, and you're offered a sign that says lane ends, share the road. And so that's exactly what she did. She merged into traffic into the right-hand lane and was promptly run over. Obviously, a terrible design, right? Could this have been prevented with improved design? I would argue that it probably could have. Designing safer streets for walkers and cyclists greatly reduces serious injuries and fatalities, including for vehicle occupants. And of course, there are good studies on this. And what I think, my view on this, coming as a safety engineer from Cal OSHA, is that if you have a hazard that could result in a critical injury or a fatality, you don't solve that problem with signage. We don't put a sign on a circular saw that says, "Don't put your hand in the circular saw." We provide an engineered guard on that saw. So the guard is going to protect you from cutting yourself with the blade. Same with electrical hazards. We use ground fault circuit interrupters. If you short circuit a piece of electrical equipment, it's not going to electrocute you. It's designed so that it opens the circuit so you're not electrocuted. We use airbags. We use collapsible design to soften the secondary impact of vehicle occupants against the interior of the vehicle. So when we look at the potential for people being hit by cars, and I can tell you, and we know from the data, of course, that when a pedestrian or cyclist is hit by a car, they don't do well. And so you need to design a system, you need to engineer the system so that when people inevitably make mistakes and they become distracted, they run into a hardened barrier rather than plow through the bike lane and then not only potentially hit someone, but then bear that responsibility for the rest of their life. So I want to touch on one other point about this, and that is that safer streets that prevent severe injuries and fatalities are also essential for firefighter wellness. And this last year, May 22nd to the 26th, California stood up a fire service behavioral health task force that ran what was called the Fire Service Stand Down for suicide prevention and awareness. And this was part of the work under Senate Bill 542, where California created a rebuttable presumption that post-traumatic stress injuries in firefighters and peace officers is a work-related injury and thus compensable under workers' compensation. And what the bill text says is that trauma-related injuries can become overwhelming and manifest in post-traumatic stress, which may result in substance use disorders and even tragically suicide. The fire service is 4 times more likely to experience a suicide than a work-related death in the line of duty in any year. So my argument here is that participating in the design of safer streets is squarely within the fire department's public safety mission and builds on decades of success in fire prevention. And we've seen in many studies, but I want to sort of highlight a particular one from 2019 that looked at 17,000 fatalities and 77,000 severe injuries across multiple metropolitan areas in the US between 2000 and 2012. And they found that areas with the most extensive networks of separated bike lanes experienced 44% fewer deaths and 50% fewer serious injuries compared to cities where such infrastructure was lacking. And the benefits were felt among vehicle occupants as well as cyclists and pedestrians because the separated lanes reduced the speed of traffic. Crashes that killed vehicle occupants, cyclists, and pedestrians dropped 61% in Seattle, 49% in San Francisco, 40% in Denver, and 38% in Chicago. So if Berkeley reduced injuries by 50%, we would be protecting 350 people on average from serious traffic injuries each year. And that would mean 350 fewer emergency runs by Berkeley Fire. So I'll close. At the Fire Commission, we advanced a street trauma prevention program effort that was then launched at Berkeley Fire with the hiring of a full-time street trauma prevention manager. And this is just our resolution that's basically establishing a Vision Zero work group within the commission, and then working in consultation with our Transportation and Infrastructure Commission. The fire department would basically be taking a proactive and constructive role in helping prevent injuries and fatalities in the street having to do with collisions. So with that, I'd like to say thank you and pass it along to Chief McHugh. Okay, thanks everyone.
Well, thank you, everyone. And in the introduction, I think it was said that I was in EMS for 41 years, maybe dog years, but in my 21st year, maybe a typo. But my name is Robbie McHugh. I'm an assistant chief of the Colony EMS department in Albany, New York. Anybody know where Albany, New York is? Just curious. Oh, okay, good. Well, great to join you today. And today I'm here to speak a little bit about or a lot about our Safe Streets for All grant. You'll notice it's a fiscal year 2023 grant. And actually, for those that don't know where we are in the capital of New York in this small area here, a capital region comprised of about 6 counties. And so we are actually strategically placed between 3 different cities, and we have pretty high-speed roads connecting those 3 cities, and we're the community that is in between all of that movement and traffic. A couple of disclaimers and disclosures. I'm not representing any federal entities, or I am purely from the local government. We're a division of local government, and I'm going to talk about some products and brands that are for demonstration purposes only, but for procurement rules, I do not want to say that we're picking any specific vendors or talking about any products. And our Safe Streets for All grant was awarded December of 23, and we are still working on executing that contract, which will make sense by the end of this presentation, I hope. I don't have to tell this audience the numbers that are staggering in roadway fatalities and pedestrian deaths, accounting for nearly 7,388 fatalities of people who are walking and died from transportation-related injuries. The Safe Systems approach for me has been a great mechanism, and I've been learning more about the world of traffic safety engineering and all the great people in this room, from planners to engineers, advocates, coming together with this shared sense of responsibility. And I just want to say thank you for including us, including EMS, in this and post-crash care in the Safe Streets approach. It's been exciting to be around all of you the last couple days. This infographic from NHTSA really stood out to me. Out of the 42,000, nearly 43,000 deaths, when EMS saw these patients, 40% were alive. This statistic is even more staggering in children. It's nearly 55% of children that we saw that later passed away and succumbed to their injuries were alive when EMS responders saw them. So some of the countermeasures that were suggested by NHTSA includes the coordination of information between emergency medical dispatch, timely response and resources, making it to the scenes, and transportation to definitive care in a trauma center, as well as the performance measures. How do we measure our outcomes? Are we measuring outcomes? And coordinating all this information and to make sure that ultimately it gets back into statewide and national data sets so we can have some proof that our interventions are working. The Safe Streets for All grant was designed to be a 5-year, $5 billion program, and ours was awarded in 2023. Interestingly, our MPO became an advocate and a partner after they saw we were interested in applying for this, and they invited me to be part of their Safe Streets grant. So we have a much larger capital region, multi-county grant happening the year prior, fiscal year prior. So it's been interesting to watch how that process has been progressing and how our plan is going to seem to fit pretty strategically into that as well. Some of the geographic areas, we are a community of about 90,000 residents, and our population nearly triples during the day due to all of our commercial properties and business, and we've got an airport centered in our town. We are the second largest town in the country, I've been told, and we've partnered this as a regional grant, so the funding opportunity nearly tripled to $3 million, whereas it would have been $1 million on our own. So we have included the towns of Clifton Park, Half Moon, the town of Colony, the town of Guilderland, and our partners in traffic safety in the Colony EMS, or in the Colony Police Department. So we cover about 30 to 35 miles of high-speed roadways, as well as responding with the New York State Police on these high-speed roads. So this proposal took a two-pronged approach, and honestly, this was a 2-page narrative for a $3 million proposal that we weren't even sure if we would get. But I figured, why not shoot for the moon and see if we could have some of these ideas tested and validated. Part one, we want to reduce further the potential for secondary crashes to occur while responders are heading to emergency calls, lights and sirens. We know that has a significant disruption in traffic flow and patterns and can have an impact on traffic, pedestrians, bicyclists, micromobility, other road users. And so our design was, or our hypothesis was, could we leverage and experiment with technologies that are standardized, they're becoming more standard, to alert roadway users that there's an emergency vehicle approaching or there's an emergency scene ahead, giving people more than just 2 to 3 seconds on average to respond to those flashing lights that they might see if they're traveling at high speeds. And let's give them more like 20 seconds to respond with a message that overtakes their infotainment system saying, slow down, pull over, or emergency scene ahead, use caution. That is a Haas Safety Cloud already uses this, that has this technology and the standard that's into most Galantis vehicles. And we trialed that in just 2 out of our 20 vehicles, and in 12 months we alerted roadway users, about 7,000 roadway users, 1,970 responses, and 543 roadway incidents, so stationary incidents where roadway users were advised of an emergency scene ahead. Again, that's 2 vehicles out of 20 in a small pilot, before we technically have even kicked off this grant, I just was interested in, can we collect more data? Can we try this equipment out? And that's what we're proposing to do across 80 emergency vehicles in these communities. All too often, people who are, really the context of a crash and the context of somebody's medical information does matter to us. If everyone here has a smartphone, more than likely they have some form of medical alert ID. If you press and hold, and you could get this set up in your own smartphone, so you can actually display who your emergency contact is, if you have any relevant health information. Our goal, though, is what if that person is unconscious? What if there is someone, a child with special needs? They might be on a special needs registry in a certain part of the state, and maybe they were just traveling through. How do we test and trial methods to get that information from smartphones and smart devices through the 911 PSAPs, those answering centers, not to overwhelm them with more information, but how do we make sure it actually goes to the MDTs and the information of responders? And that's really our goal with investigating different technologies that I'll talk about. And how do we use vehicle telematics in order to improve the maintenance of vehicles that are on the road? Several times in this conference it was brought up that we have the ability to influence our fleet vehicles maybe more than the public sometimes. So how do we make sure that our telematics are telling us and warning us if there might be a potential issue? We've been trialing Samsara devices and platforms as kind of the Internet of Things connectivity platform, so we can take all of these different sensors from Goodyear tires with sensors built in telling you the tread, to other things that might give you a red flag about what might be wrong with that emergency vehicle that's operating on the road, lights and sirens going potentially high speeds. That's a little bit about our initial idea. Other technology that we're looking at is how do we make our emergency responses safer for all patients? For that mom that's expecting, making sure those seatbelts are properly positioned that aren't going to cause further injury if there was a crash in an emergency vehicle. How about mom who just delivered in the field, making sure that mom's not just holding that baby, but there's a crash test rated Aegis wrap that is promoting skin-to-skin contact, preventing hypothermia, and actually a safe method of transporting that newborn in that field delivery to make sure mom and baby get to stay together right after that happens. And other emergency child restraints and that will keep the baby safe if there's an emergency or if there is an issue with trying to secure that car seat. Other technology that will keep projectiles from actually causing more damage if there was ever an accident in an emergency vehicle. One exciting technology that I'm going to touch on that was kind of added to this over the last year was currently there's about 38 states in the United States that allow pre-hospital blood administration. New York State was just voted through the legislature allowing us to carry pre-hospital blood. And now we are in the rollout stages of planning this process. A very expensive, very vital, critical resource that has such an impact on somebody's chances of surviving a crash. For every minute of delay in a transfusion, the odds of mortality are actually going up 11% with some studies. So the chances of improving patient care have been proven with recent research. This is a picture of the Dallas Fire Department with their blood coolers, temperature monitors, blood warmers. You have to keep it cold, and then you have to warm it up potentially to administer it. And how do you rapidly infuse that life-saving blood to resuscitate someone? The Pre-Hospital Blood Transfusion Initiative Coalition has identified areas of the country. So if you see your home up here, where you could check out this website and actually see who is carrying pre-hospital blood, which will definitely improve post-crash care. Partnering with our traffic safety division and having conversations, having a seat at the table to talk about what other technologies would they want to explore. They have outdated speed trailers that could potentially be updated to create a live speed network that gets deployed in that corridor I mentioned earlier that is unfortunately where a lot of fatalities happen due to speeds. So our plan is to deploy fixed and mobile variable speed signs that are actually reporting in real time to a live speed network, so law enforcement can go out and deploy resources to areas where speed is happening almost in real time, rather than having to download the information from that speed trailer, analyze it, and deploy resources or respond to that complaint that somebody was speeding or driving erratically. So we're pretty excited about collaborating with that as an effort in the safe systems approach to reduce speed on the road. I told you this was a two-part approach. The second part of this approach is the idea of a pre-hospital health and safety information exchange. There are current standards out there that allow for the safe and effective transmission of our protected health information between providers, and especially there's clauses in emergency care where if somebody's having an emergency, we can, some places call it break the glass, and access that information. We don't want to give a first responder access to this information and tell them they have to log into a website and do a two-factor authentication and wait for the code. We want to use existing platforms. So one platform is Pulsera, where we can scan a driver's license. It pulls in their demographics, so there's no typos. We get their name, date of birth, and our concept is that this will ping structured data sets out there in New York State. We've got the New York State Shiny and health information standards across the state. And it might say, well, this patient has a specific bleeding disorder. They might normally be nonverbal. This patient may actually be part of a Handle with Care registry, so they might have a special need, or they might be nonverbal. So all of that information, without flooding our providers with 1,000 pages of medical records, we want to get what are the top 3 things we should know right now that are going to help us impact and influence that care. So that's the design, as well as the ability to link hospital outcome information back to a state and national data set. Currently, the NEMSIS data set is collecting over 50 million records a year from pre-hospital providers. Less than 2% contain outcome information. So we want to make sure not only are we going to get the discharge information from the hospitals back to the state and the national data set, we want to make sure it gets back to our providers so that impacts their future care, the care that they're going to deliver in the future. They can become a better provider knowing what happened and what was the outcome of that patient rather than speculating or never finding out. So that is a little bit about our two-part approach, and frankly, this did send me down quite the rabbit hole of traffic safety engineering and getting to talk to fantastic people like yourselves in this room, learning more about in-road warning light systems, and this is part of that part 1 approach, is what is other technology out there that's underutilized but MUTCD approved that we could trial. Now, if you ever want to have an interesting conversation, you can suggest in-road warning lights or in-road anything to somebody in New York, and they will certainly give you all the reasons why it may not work, but certainly it's been exciting to find folks at the state level that are willing to try out and experiment with new technologies, and that there are plow-safe versions of this, and they might be willing to give them a try. Other things like rapid rectangular flashing beacons. I've never been more excited to see one in the wild and actually know what it is. But now I'm fascinated by that, as well as our pedestrian refuge islands. This is certainly an issue. This could be a picture of 3 mid-block crosswalks in our community in a 40-mile-an-hour zone that people do not want to stop for because they know they would probably get rear-ended. This has caused a lot of injuries in our community. So hopefully with proven concepts like this, we can implement and trial this, as well as potentially scale it to other communities. We mentioned earlier that most of our fatalities, we see 85% of fatalities happen from dusk to dawn. Are we analyzing these crosswalks during the day in good lighting conditions, or are we actually going to analyze the condition of crosswalks in our community at night? I mentioned the speed feedback signs, but there's other potential crosswalk lighting and mid-block crosswalk lighting that we can experiment with. This all came full circle after about 9 months of us getting this award. Everybody kept asking, so how are you going to pay for this? How are you going to pay for that? Find that local money. And so I just continued to have conversations with various stakeholders, including the State Assembly in New York and our Assembly member ended up getting one of the most powerful people in the New York State Assembly, Carl Hastie, to come to our community with a $650,000 grant. So we was technically more than we asked for, and we weren't going to complain. But certainly we're excited to kick off this project, to get a contract signed, and whatever happens with the federal money, at least we know we will have some state money that's secured if we have to do this on a smaller scale. But with that, I just want to thank folks at the Lifesavers Conference, the New York State Governor's Traffic Safety Committee for being very excited about this project and wanting me to present this at various places, and then nudging me to come out to California to promote at a conference I had never heard of, I'm sorry, the Lifesavers Conference, but I'm glad that I did, as well as New York State Department of Transportation, both at the headquarters level and Region 1. They've been very excited about this. And our Capital District MPO, that's invited me on more committees that I know what to do with when it comes to other corridor studies and speed studies. So. Thank you.
Thank you. Okay, now we're going to go ahead and open it up for questions for our panelists today.
Hi, thank you all. My name is Virginia. I'm from the city of Philadelphia. And I just want to say it's so refreshing to hear these takes from people who are actively doing this work or who have previously done this work of first responders. So thank you for that, just as a nice thing. But we are doing lots of Vision Zero planning very actively right now in terms of bringing people to the table, bringing stakeholders together to kind of do our next action plan so that we can do our programming and kind of plan for the next 5 years of funding and programming. But it's critical that we bring our first responders to the table and make sure that they are being heard. And I think it's like we all agree what the problem statement is, but sometimes it gets a little harder to pull over with what the solutions are outside of what are the traditional forms of kind of traffic safety solutions, or at least things people are comfortable with. All that to say, what would you recommend as that first step to get folks to where you have gotten in terms of your kind of belief in these kind of treatments?
I'll jump in. Okay, I'll start. Yes. So, the way that I sort of presented this, it was a very logical sort of step-by-step sequence that played out, stepwise, and of course it hasn't been that way. And it took us, probably about 1.5 years in working with the leadership of Berkeley Fire Department and the Firefighters Local Union leadership in moving from what had been a pretty confrontational relationship between street safety advocates and the position that the fire department was finding itself in of sort of opposing street safety measures, but also without a lot of data to actually back that up honestly. It was more of like an intuition that they had that this is, their primary mission is emergency response. And so everything that had to do with street safety that was driving down the sizes of streets or bulb outs or what have you looked like an impediment. And they were already concerned about their response times. And so I think the thing that was the most important in this was approaching this through the successes of the fire service from the prevention side, and that reframing the question of street trauma as something that requires both response and to acknowledge that, and also prevention, and that lifting up the real record of the fire service in fire prevention and saving thousands of lives over the last 50 years across the country, and that just acknowledging that the fire service has done an exemplary job on that front. That sort of was a shift in framing to sort of like put it in a more positive light, and recognizing that the mission of the fire service, maybe it's bigger than just responding to emergencies. It's really about building a safer city. And I think to the credit of the Berkeley fire chief, he was able to get on board with that sort of paradigm shift really in thinking about the role of the department is. So, and I'll just say one other quick thing about that, and that has been that, and Chief McHugh will probably attest to this, that the fire service every few years has taken on a new mission. Hazardous materials, technical rescue, paramedic work, what have you. And it's an expanding all hazards just mission for the fire service. And so it's another kind of expansion of the mission, but the fire service has experience with expanding its mission too. I mean, it's part of the way it has grown up in the US. I don't know.
Yeah, I'll comment a little bit about that. Feel free to just reach out to your local emergency services personnel, your EMS delivery method. Every community is different and served by paramedics serve in a different capacity. My department is a municipal department of local government. We are EMS only, and we do technical rescue, including kind of this all hazards approach to hazmat response, to swiftwater rescue, and other technical rescue. So we are not in the fire suppression world, other than we support 12 different fire departments. So EMS delivery in the United States is pretty fractured and siloed. You've got fire departments delivering probably around 30 to 40% of the delivery model. You have private nonprofits, private commercial, you've got hospital-based delivery, and then you've got the municipal, local government, they call it the third service model. So maybe get familiar with what EMS looks like in your community. Is it even being an essential service in your community? Most people don't realize that actually EMS is not required in their state as an essential service. The designation we've been working on getting that passed in New York State. And it's interesting that we were allowed to carry whole blood last year, but the legislature did not pick up and pass the legislation to make us an essential service. And it's always interesting to look at the essential service designation with essential service funding. Is there a funding mechanism? The funding mechanism in the United States is a little bit broken with EMS. We typically get reimbursed less than the cost of care and have to rely on a subsidy. So if there is any type of grant funding that can be brought to the table, especially if you show those responders that, look, you're right here in the safe systems approach, like this may enable you for a stream of funding to get into this world of prevention. We love to talk about CPR in the world of prevention and making sure people are prepared for an emergency, especially, this is just another way to go upstream to get to the source of preventing a lot of these issues rather than constantly dealing with the aftermath and the constant responses, the death, the disability, because it does have a toll. Mm-hmm. Statistics showing 100, the average first responder sees 100 traumatic experiences per year versus the average civilian seeing 3 in a lifetime, which is a pretty staggering statistic. So it definitely has an impact, and I would say if you can just make those connections and point out to the safe systems approach that there's a place for you here, make a huge difference. So
that's a great point.
Thank you. Hi, Jonathan Fite, Beyond Lucid Technologies, and I live on the other side of the 24, so very familiar with Berkeley and some of what goes on in that country. I guess if I can ask you to sort of riff a little more on what the two last responses, but maybe to all of you, when it comes to, you've each sort of danced around the topic of politics a little bit, when it comes to actually acquiring tools, when it comes, or tools and technologies and approaches, when it comes to knowing, for example, when you've got, again, thinking about an Alameda County, very complex place with a lot of stakeholders who some are going to hate whatever is suggested, and some have the things that they love the most, and that's what they want. What has been your experience in terms of navigating to get to an endpoint to determine that what you're about to invest in, whether it's time or money or training or whatever, is the right thing, as opposed to what someone local may have wanted? In other cases we've seen in Alameda County where, for example, someone worked in government, put something in there, and then ended up working at that company later on. So there's a lot of delicacy around that and some real experiences. How do you make sure that the investments are going in the right place that are productive based on the local politics and the economics?
Yeah, I mean, okay, so, I mean, I think it's every one of these things is kind of case specific. And I think the precipitating event that really brought the fire service kind of front and center into this world was a big, really important project that had been many years in the works in Berkeley to put in a two-way cycle track on an important street that access of middle school and a number of other important kind of, target populations. And it was the fire department in the end sort of weighing in to say that we think this is going to have an impact on our response times and maybe our evacuation strategies and so forth. That was sort of the last straw for the city council. And that was a kind of extraordinarily divisive event that happened in the city. And so sort of navigating the politics of that and sort of sitting down, I think for me it was kitchen table diplomacy with the fire chief, and to sort of just acknowledge his humanity in recognizing that that was a terrible position for him to be in. And he wants a safe city. His kids bike to school, but it was working with him in a one-on-one, behind-the-scenes kind of relationship building, and not sort of calling him out publicly or what have you, but really building that relationship, and sort of recognizing that his call volume, and this is kind of, as Chief McHugh has just said, it's about 80% of what happens in most cities across the state. It's about 80% is emergency medical services, EMS calls. A lot of those are for trauma, and so he had an operational pressure on his equipment and personnel that sort of speaking to him from the interest of his operational needs. One of them is to drive down those responses if possible. Can you prevent those? And I think Chief McHugh's point about exposure to trauma, another thing that he acknowledged was something that he, as an administrator and leader of his folks, needed to get really get a handle on in a substantive way. And so there's there's interest in terms of the sort of public role of the fire service and protecting the mental health of firefighters and paramedics. That's really right in the center of the fire chief's mission. And so we really approached him through that sort of lens. And in terms of the solutions, again, we're sort of relying on research that's out there, and there are some good studies that we're drawing on to really advocate for protected. We're not relying on paint. We're not we're relying on concrete and parked cars to protect people, and that's sort of what we're going for as the primary objective.
If I can just follow up real quick, and maybe some of this is for offline, but I would be remiss if I didn't ask, because you mentioned things like preventing unnecessary calls.
Right.
But for example, Berkeley Fire bills for its services, for the ambulance service. Berkeley Fire bills for its ambulance services.
Right.
So did you run into challenges around the idea that on the one hand, you're making the community safer and less risk to everybody. On the other hand, you're taking money out of the system. So did you find that there was a tension in that around we need to run a certain number of calls to make our number? If we do too well on this side of avoiding those encounters, we actually reduce revenue.
Not at all. Not at all. Yeah, not an issue.
Thank you.
Yeah.
That's great to hear that there was no pushback from that perspective. I will say in the pre-hospital blood world that this is an extremely expensive intervention, and we're talking about $600 to $1,000 per unit of blood between the acquisition and the equipment alone. The equipment side of it is $12,000 to $15,000 for a cooler on the high side, and so there are certainly a lot of concerns there, and we need to figure out alternative funding strategies of how do we make sure this really vital component can get to those who need it the most. And how do we convince our elected officials that this is a worthy investment, that we could possibly tap into state funding or other funding sources to help us with those increased expenses?
Okay, perfect. Well, it is 2:45, so that is the end of this session. You guys do have an hour break until the next set of workshops start. Do not forget, this is the last day to check out any of the exhibits in the exhibit hall because it will not be open tomorrow. So you've got about an hour to go check it out. But thank you guys for joining, and thank you to my panelists for today.
Thank you.